Great. Well, it is time for the John Conley Lecture. And obviously, this is one of the most important and traditional lectures of the American Head and Neck Society. You can look in the program if you happen not to know the biography of Dr. John Conley, which would be absolutely taken against you if you don't. But this year, John Conley Lecture is delivered by someone who actually delivered the John Conley Lecture for the American College of Surgeons this past meeting. So Professor Michael Porter has been a favorite John Conley lecturer, both for the American College of Surgeons and today for the American Head and Neck Society. Now, I met Professor Porter at MD Anderson when he decided that he wants to look into cancer care delivery models and wanted to study MD Anderson. And the then president of MD Anderson, John Mendelsohn, told him that, of course, he can study breast or lung or prostate or colon, and these will be the big four. But if he really wants to see the essence of how MD Anderson works, he needs to study the Head and Neck Center, because that was the flagship of multidisciplinary care at MD Anderson. So we were flattered twice. One, by the compliment of the president, but also by Dr. Porter's intent study of our center. Ever since, we have collaborated on teaching the MD Anderson Harvard Business Case Review in their annual meeting in Boston in January. And I can't think of a better month to go to Boston other than January. Now, if you recall that a year ago, we decided to have a theme for our meeting, value-based healthcare in head and neck cancer. And if we're going to have a theme on value-based healthcare, who better to represent the John Conley Lecture than the man that coined the term value-based healthcare, and that would be Professor Michael Porter. Now, his initial training was in aerospace engineering at Princeton, then went and took an MBA from Harvard and a PhD in business economics from Harvard. Seems to have sort of knocked every door in Harvard. And in 2000, the Harvard Business School and Harvard University jointly established an Institute of Strategy and Competitiveness and provided a home for his research. Now, his early work focused on industry competition. And I know you can't read all this, but I'll sort of summarize it to you. And he published several books and articles, including Competitive Strategy, Competitive Advantage, and What is Strategy? And these are taught in virtually every business school in the world. And even though I have very little time to keep up with all the medical literature, I did read some of these books, and I would recommend them to you highly because they apply to just about everything we do. And then Dr. Porter then turned to economic development and competitiveness, and he took the strategy and competitiveness into the competitiveness of nations, and the book Competitive Advantage of Nations, published in 1990, was the foundation of all this body of work. And he, based on that, advised many heads of nations, including our last 6 presidents. I'm not sure the current president takes advice from anybody, but that's besides the point. He authored 19 books and 130 articles, and a lot of awards and honors, but I'm just going to mention some of the most important ones. The Adam Smith Award for the National Association of Business Economists, the John Kenneth Galbraith Medal, and the David Wells Prize in Economics from the Harvard. And he also has the unprecedented honor of a 7-time winner of the McKinsey Award for the Best Harvard Business Review Article of the Year. He, in 2016, received the Chef Medal for enduring and transformational contributions to marketing scholarship. and he received the first ever Lifetime Achievement Award from the U.S. Department of Commerce for his contribution to economic development. Now, all of that preceded Professor Porter's delving into healthcare. And this is an excerpt from the book that he wrote, a defining book by him and Elizabeth Teesberg. And it's a very personal excerpt where Elizabeth had a newborn son with a congenital heart problem, and Mike, as a friend, was trying to help her, both of them, find the very best doctors to deal with this very complex problem. And they were saying in this excerpt, a very personal statement, that yet as the system was performing a miracle, getting the right doctors required circumventing the normal system. Even more troubling was the protracted struggle to get reimbursement for the care delivered. Since then, Mike Porter devoted all of his attention to the economics of healthcare and built the framework for what we now know as value-based healthcare with all its different components, not only in the book, but in the New England Journal of Medicine, several articles, What is Value in Healthcare, the strategy that will fix healthcare, and how to pay for healthcare. So, in summary, I would like to welcome Professor Michael Porter, who is known to us as an economist, researcher, author, advisor, speaker, teacher, and for me, a friend. Mike?
My gosh, that was too much. But Ahab, thank you very much for that remarkably kind and generous introduction, and it's a joy and thrill for me to be here. And the only complaint I have is I don't have enough time, because what we're going to talk about today is really an overall strategic framework to look at what you do. I've been wandering around outside. There's all kinds of scientific things out there, all kinds of studies, all kinds of therapies, all kinds of drugs. There's all these pieces of what you do, and they're all important. But this work really has tried to fill a need which I felt in healthcare, which was, how do we think about the overall system, our overall organization, how we structure it, how we measure, how we engage staff in the optimal way. I think we spent a lot of our focus in healthcare on medical science, and let's keep doing that. But what I've come to believe is the constraint now, the biggest single constraint, is what you might call delivery science. How do we actually deliver this stuff? It's really complicated. This is the most complex service I've ever studied. I've looked at almost every industry in the economy. So that's what today's session is about, and that is, of course, a holistic topic, and we'll only be able to get started. But we have included references. There's now lots of videos. There's curriculum that's now creeping into medical schools around the world. And I think this is not a substitute for all your medical expertise and the tremendous power of medical science to make things better for patients, but it's a complement. And hopefully it will provide a way of looking at what you do that will be helpful. Now, I just want to say one thing before I dive in, and Ahab may or may not remember this, but my mother died of head and neck cancer. And that, in a sense, was an incredible draw to immerse myself in this field. And I discovered it's a really complicated form of cancer. It's quite rare. If you're not in the right place, you've got a problem in terms of getting the right care. And so, in a way, head and neck cancer became a metaphor for a lot of the most challenging issues we have to deal with in healthcare. I'm going to show you this. I'm a strategy professor, so I have more than normal of these advisory roles. But let's kind of dive in and go very quickly here. And the starting point here is we haven't solved the problem of healthcare. We've been working on it for decades and decades and decades. We've been saying it's too high cost for decades. We've been saying that the outcomes are uneven. We're saying we have a problem here that's an epic problem. It's the #1 problem that among American households. This is what they think is their #1 problem. It's obviously having a tremendous impact on our budget. Because the cost of health insurance, even today, is going up twice as fast as the average income. We've got a problem here. We've got a cost problem. We have an outcome problem. But ultimately, I think if we're going to solve those earlier problems, we've got a delivery problem. Or at least we can do it better. And that's what this body of work is all about. Now, it's not that we haven't tried to improve healthcare delivery. There's been a lot of terrific work done by, a lot of terrific people. I happen to be a very close friend of Don Berwick and served with him on a board, and he's done marvelous work on trying to improve healthcare. There's lots of marvelous work. I've just put up some of the streams of improvement work in healthcare that we see every day. Some of them, are possibly disasters. Prior authorization, do you think that really improved healthcare very much? Did it create a pain in the butt for all of you? Yes. Patients as paying customers, there was a big idea if the patient pays, they're going to pay more attention, they're going to use healthcare more selectively. What has that turned into? A nightmare of copays that people can't afford anymore. So some of these things were clearly not correct, but a lot of these things made sense. We need to try to deal with errors. We need to have evidence-based processes in care, and so on and so on. And I just took a little shot at IBM Watson. That's the most recent kind of. IBM Watson was going to teach us all how to do healthcare, and so far the evidence is not very compelling that IBM Watson can help us. So, but if we think about these solutions that we tried, and we'll continue to try, and we'll continue to have ideas. And great people will do that work, and we hope they'll continue to do that work. I think when we look at these, the biggest problem here is all of these what I call incremental solutions. We have a system the way it is today. You all know it much better than I. We have ways of doing things, and all of these things are what I would call overlays. We're going to leave the system basically the same as it is, but then we're going to overlay an idea like prior authorization or put in care coordinators that will kind of coordinate the complexity and the management of patients. Those are all good ideas, but ultimately if we don't change the underlying design and structure of how we do this, these things won't ultimately be powerful. That's what we found. We need to step back and look much more deeply at how we think about healthcare, how we organize it, how we measure it, how we lead it, how we manage it, and that's what this value-based healthcare work has started to do. And I think what I would tell you is so far so good. There's a slide at the end of this presentation I probably won't get to, which shows that in the medical literature and the peer-reviewed literature, value-based healthcare is exponentially increasing. We've had lots of value-based healthcare efforts all across the world. So it's happening, but it's complicated. And it's not the thing most people in healthcare sort of get trained to do, which is be managers, be strategists for thinking about how your organization actually is functioning and how it could function better, but not in the individual discrete care for this cancer version or that cancer version, but looking at it holistically. So value-based healthcare is an attempt to start to provide a framework that will guide substantial innovation in care delivery over the coming years. And I think head and neck cancer is an area where I think a lot of you intuitively get this because of the nature of these cancers and because of the nature of the treatment. For example, one of the key ideas in value-based healthcare is the idea that care can't be provided by individuals. It has to be provided by a multidisciplinary team. And those people have to work together, or we're never going to get there. And, head and neck cancer, multidisciplinary team is just religion. I mean, we got to deal with swallowing, we got to deal with speech, we got to deal with all kinds of issues in head and neck cancer where we need a team. But it's a hard thing to construct and to manage, particularly in today's healthcare system. So let's talk a little bit about value-based healthcare. Again, I'll go relatively quickly, but I hope any of you that find this even somewhat interesting will dig a little bit deeper into the literature here. We have a large body of case studies that cover almost all disease areas that we can make available to you, that we teach in our curriculum at HBS. We've got quite a bit. We actually have a new journal now for value-based healthcare. You haven't heard of it yet, but very soon the New England Journal of Medicine is going to announce New England Journal Catalyst. And that is designed to be the journal of record for value-based healthcare. And so the body of literature, the experience is growing. Here we can't cover all that detail, but at least hopefully I can give every one of you a starting point for thinking about what this is all about. Now, the number one starting point for value-based healthcare is that if you're going to have success in any business or any endeavor, you've got to start with clarity about your fundamental goal. What are we trying to achieve here? The problem we've had in healthcare is there's too many goals. If you look at the Institute of Medicine, they have 5 or 6 goals: equity, efficiency, patient-centered. We can rattle off a lot of goals in healthcare. But without an integrated, sort of central way of thinking about our purpose, we are handicapped in actually making progress. And this whole body of work starts with a very simple idea that the fundamental goal of healthcare is delivering value to the patient. That's why we exist. That's what we're doing. That's the point. That's the purpose. If we deliver good value, we're successful. If we don't, we failed. If we improve value over time, we're successful. If we don't, we failed. It doesn't matter how good the surgeries were. It doesn't matter how smart all our people are. If we're not actually improving value, and if we can't prove it, then we're not succeeding. And what I discovered, to my surprise, is that healthcare, of all the industries I've ever worked, is in one very important way a fact-free zone. Because we don't know what the value is. We really don't know the outcomes. We might have a 5-year survival, we might, but that's not the only relevant outcome in this disease. And we don't really understand our costs. We know what our charges are. We know how much we bill, but we don't know what it actually costs us to actually deliver care. That's because all the cost accounting in most of your organizations is flawed. It's departmental costing. We don't care about the cost of the department. Somebody does, but not society. What we care about is the cost of delivering head and neck cancer care for whatever variety of head and neck cancer it is to this patient over the whole cycle of care. That's value. We have to understand the outcomes that really matter, and we have to understand how much it costs to deliver care to a patient over the whole process of dealing with whatever condition they have. That's the goal. That's value. And what we've come to believe is that if we keep that on the top of our mind at all times, it's about value. Value is about outcomes and value is about costs. If we keep that on top of mind, we will be able to move forward. But if we get confused over all the many, many other things that we want to do, like improve our research or train our fellows better or, et cetera, et cetera, et cetera, then we can still get better, but we're not going to be as powerful. We're not going to get as big a success. So the nice thing about value also is it's not a zero-sum goal. Value is a positive-sum goal. If we can improve value, our patients are going to love it. Okay? If we can improve value, our society is going to love it. If we can improve value, health plans, the dreaded health plans, will love it. It's a win-win goal. So much of healthcare is about win-lose. oh, let's bargain more with our insurance company and get higher reimbursement rates. And the insurance company has the opposite goal, push down the reimbursement rate. That's a zero-sum goal, but value is a positive-sum goal. If we improve value, everybody wins. And therefore, we ought to have a lot of allies, and we ought to be able to work together on value improvement. And we're starting to see that, but it's not easy. So the real question is, how do we create a value-based healthcare delivery system? What does that look like? What are the dimensions of that? And here, I think we all have to remember that we have a long legacy in healthcare. Healthcare has, it's been out there a long time. The way we organize healthcare delivery today has been in place for decades and decades and decades and decades. We organize around specialties and departments. And that's because that's the way we're trained. And that's the way most hospitals now are structured, or even cancer centers in many cases. And intuitively that seems logical, but it turns out that way of organizing actually works right against value. It works right against value. We have a lot of payment models. We have payment models, fee for service, number one, which is it's opposite to value. If we pay for fee for service, we get rewarded for volume, not value. We get paid more if we don't do well. So how do we, and not only that, but the fee for service model also reinforces our fragmentation, because everybody gets their little fee for their little thing. And people have come to expect that this is the way it is, okay? So you can see now we have a legacy to overcome in healthcare that's greater challenge than the legacies we have in many other fields. We also have had tremendous advances in medical science over time, and a model that worked 20 or 30 or 40 years ago with what we knew how to do then doesn't work so well when we have many more options, many more procedures, many more drugs, many more things we can do that involve multiple people that have to work together. And there's so much to know. Again, one of the things in healthcare is people tend to like the idea of doing multiple things. Oh, I do heart surgery, and mostly I do heart surgery for adults, but I'd like to do some pediatric cases. It's interesting. Get to do a lot of different things. But what we understand in healthcare is if we do a lot of things in this world we are in today with all the complexity and all the options and all the knowledge that we have, it's going to be hard to keep up. So in developing value-based healthcare, we have to just not assume any of the legacy makes any sense. Some of it is downright destructive. Some of it's just benign. But it's confusing us. It's diverting our efforts to actually transform how our organizations work. And, what do we do? What's a strategy? And the strategy is a holistic view of how we would transform the value that we deliver in our organization. Every one of you are in an organization. Think of that in your head right now. Think about how well your organization is actually serving patients and delivering value. But think about it holistically. And what we're going to talk about is, well, what are the key things we've got to get done if we're going to really change that? That's the key idea of value-based healthcare. Now, the first point we need to make about value-based healthcare is that we can't think about healthcare and value at the level of a hospital. You literally can't calculate the value of a hospital because there's thousands of different things happening where the needs are different, the economics are different, and the costs are different. We can't measure the value of a hospital. We can't even measure the value of a surgeon, believe it or not. This might be a little controversial. You're going to do your job, and you're going to do a good job, but the value to the patient doesn't stop with your surgery. It's affected by everything else that's going to happen. And a lot of other people are going to have a lot to do with the value that you may have created over time. So value, you've got to think about value around conditions, what we call medical conditions. the patient's problem. And head and neck cancer is complicated. I've been dreading having to pronounce, the laryngeal and pharyngeal and all those things. It's complicated. There's multiple different conditions within head and neck cancer. And if we're going to understand value, we're going to have to go condition by condition. We can't even calculate the value of head and neck cancer. It's diverse. It's a lot of different things. There's a lot of different needs involving lots of different technologies. So we've got to learn how to think about the right unit of analysis in healthcare. And that's been one of the fundamental problems because we've organized around specialty, and the specialty isn't the right unit of analysis. And that's held us back. Another key concept in value is we can't think about an intervention. We have to think about the full care cycle. We can never just think about one step. One step, we can't figure out the value of the one step. The only way we're going to understand value is going to have to see the whole process, because the whole process is going to generate the cost, and at the end of the day, the whole process is going to determine the outcomes. And therefore, the only way to understand value is to look holistically at the whole thing. Now, most of us in this room are surgeons, and we do the surgery part, and that's a really big part. And in many head and neck cancer settings that I'm aware of, you have teams and you do work together. But rarely have I found really people that think about that whole cycle of care. And we have to do that if we're ultimately going to achieve what we know is our purpose as a healthcare system. So the value equation is kind of simple there. The set of outcomes that matter for the condition, whatever condition we're looking at, realizing that there's lots of them. And then the costs that matter are the total costs for delivering that care over the full cycle of care. I won't talk about primary care today, but there's another body of thinking about how do we think about value in primary care, which is hard as well, because primary care is holistic. And we have a primary care practice where a doctor has 100 patients or 200 patients, and those 100 and 200 patients have every conceivable different problem in the world. Some are almost dying, some are happy, some are unhappy, some are mentally ill, some are, have a clear problem like diabetes. Primary care, the way we do it today, is mission impossible. How could a primary care doctor be high value in delivering care for all of those different patients with all those different needs? And so what we're coming to understand is you can't deliver primary care for a broad group. You have to segment your patients to understand their primary care circumstances and the needs they might have if we're going to do good primary care. And we're starting to see really powerful, exciting new primary care models that are starting to work. But you can see the problem has been the legacy. We have some of the most brilliant people on the face of the earth sitting in this room. You work really hard. Really hard. You're massively well trained. It takes you your entire life to get trained. Then hopefully you live long enough to use the training a little bit. This is the best and the brightest in this room. But ultimately, we're not going to succeed as individuals unless we have a way of thinking holistically about the whole system and our whole organization, which is going to inevitably involve a lot of other people. And we don't tend to do that very much in healthcare, is what we found. So let's start talking. So what we've come to understand is that to move to value-based healthcare from where we are today, there's what we like to call the strategic agenda. This is what we have to do for our organization. And it really involves, 6 major transformations, none of which are particularly easy. That's why healthcare keeps struggling. It's not easy. Number 1, we've got to reorganize the way we actually deliver care. We can't do silos anymore. We can't do specialties anymore. We can't think of it that way. We have to provide integrated care, organized around whatever condition we're caring for. And all. Is that me? I don't think so. Wow. Gosh, I'm getting a message. So anyway, we got to do integrated care, okay? So care reorganization, and the key idea that we use for care reorganization is the concept of IPUs, integrated practice units. How do we put together an integrated team and manage that team so that it can actually work in a most high-value way in delivering care for that disease over the whole cycle of care? So that's number one. Number two is we've got to start measuring. We found in every other field of human endeavor, if we don't measure what success is and know how well we're doing, then we're not going to make that much progress. So we got to learn how to measure outcomes. Some of you measure some outcomes. Very few people in head and neck cancer or any other cancer measure all the relevant outcomes. We'll talk about that a little bit later. We also have to learn how to measure cost. If we can measure cost the right way, I will guarantee you that you can lower costs by at least 25%. We have dozens of examples. We've been piloting this with lots of organizations. We don't do things, it must be me. But it's that second one that bothers me. I don't understand. The first one I understand. The second one I don't understand. Okay. So we got to measure. We got to measure things that are different than what we measure now. We measure now, process compliance. Okay, that's fine. But what we know is that complying with process doesn't guarantee the outcome because it's too complicated. There's too many other things going on. And so we got to learn how to actually measure the outcome. And we learn how to measure the cost. We've got to change our reimbursement somehow, someday. And after many decades, we're finally starting to move to what's called value-based reimbursement. Value-based reimbursement is based on the value we deliver, and that's measured in terms of the total delivery of care for whatever the patient's problem is. So we'll talk a little bit about that. This is now scaring me. Something bad's going to happen here. Okay, so the fourth point is we've got to, when we are in a delivery system or in a delivery organization, we've got to integrate across all the sites in that organization. We can't just think about our site in our hospital, because to deliver high-value care, we shouldn't perform all the care in that site. We ought to perform, if we're going to do chemo, we don't need to do it in an academic medical center that's high cost. We can do it in a suburban unit, in an affiliation with a community hospital, and supervise it. And that'll dramatically reduce our costs. But if we think of everything happening in our site or our hospital, which is a tendency I think we have in this field, we're not going to be able to deliver as much value. The same thing is true about geography. So many healthcare delivery organizations really think about their immediate population and serving the immediate population, but we need to stretch our geography. And what we're finding is fascinating and powerful affiliations that this provider has with these other providers in the general region, and how they can tune the acuity up by doing the stuff in their facility that they should be doing, and they can actually refer care to other people who could do it just as well at much lower cost and much closer to home. And so there's an integration across sites and across delivery systems. We have a delivery system in Boston called Partners Healthcare. It's a great organization and it's got a lot of smart people, but Partners, Brigham and Mass General duplicate every single thing they do. Each one has a kidney transplant unit. Each one has a heart transplant unit. It's crazy. But that's the way we think in healthcare. We think, if we're at Mass General, we need to serve any need that shows up at the day. So that's something we got to work against as well. And then finally, we have to make information technology work for us, because it's critical. This is a very information-rich industry, and we got to pull that information together, and we have to use information technology to measure better, to understand our costs better, to understand everything about that patient from soup to nuts in one place, and we've been struggling. The reason we've been struggling is that information technology is hard, but think back in information technology. Information technology was created around the silos. There were billing systems, there were operating room management systems, there were all kinds of individual best-in-breed software about the parts. But until recently, we have no software technology that allows us to pull everything together and allow us to interact and communicate and share information. It's starting to happen, though. It's starting to happen, it's happened slowly. If you've had an Epic implementation, it's probably not been fun, okay? And it's highly imperfect, but at least we're starting to move in the right direction, and I think finally we're starting to get the software platforms that we need. Okay, so let me just spend a few minutes talking about each of these and just give you a few of the key ideas, and then we can move forward. Oh, by the way, before I do that, let me just say from my perspective as an outsider, although I have, and don't blame AHOB for any of this, by the way, this is kind of my view. What do we got to get done in this particular field? Well, one is we've got to learn how to manage these complicated multidisciplinary teams that we have to have. And to do that, we're probably going to have to integrate them, and they're probably going to have to be part of the same organization, and there are other dimensions of that. So that's number two. We've got to measure outcomes in this field. We measure some, mostly survival, but it's much more complicated than that, and we got to learn how to have universal standard measure of outcomes in this field by condition. And we haven't gotten too far down that road beyond the 5-year survival. And we got a harder job than many cancers because there's so many different things here. I now know that skull base is different than here, and that's different than here, and that's different than here. And you guys know all that stuff. It's complicated. The only way we're going to succeed in a complicated field like that is we're going to have to segment what we do into the patient's need that we're solving, and then we're going to have to think about how to measure the value we actually delivered in that. And we're going to have to go way beyond survival. If the patient is disfigured, that's an outcome. If the patient can't eat normally, that's an outcome. And that's just as important in some ways as the survival data for many patients, if not more important. This field needs a national and international disease registry where these outcomes are collected by everybody. And everybody's measuring the same standard outcomes that we agree on as a field with our best minds. And obviously they'll keep getting better. But when we have those registries and we can pull everything together, we learn and we get much better, and I'll show you an example a little bit later on. We have to move ahead on reimbursement models. There's been one effort at a value-based reimbursement in head and neck cancer that I'm aware of, which was at MD Anderson. I'll show you that in a minute. But ultimately, we got to get paid for delivering value. And if we're just paid for doing stuff, then we're not going to be rewarded for spending the time and the energy to deliver value. So we got to change the reimbursement model, and we need more innovation in this particular field. We see a lot of innovation in reimbursement in orthopedics. Maybe that's because it's a lot simpler. There's thousands and thousands of bundled payments now, which is a single payment for the whole process of care in orthopedics. But in head and neck, it's too complicated, but we've got to overcome that complication. I know we can. And then what I'm struck by in this field is how we got to get the patient to the right place. Because if they start in the wrong place in this complicated field that's not high volume, then there's nothing we can do once they get to us. And the costs explode. And the outcomes sink, okay? So I think part of our strategic agenda has to be to coordinate very well with all the other actors that are touching head and neck patients in our region, and understand how to get the right patients that need to be in our high value tertiary medical centers, but the patients that can start somewhere else and get some other care first before they do that. We've got to learn how to manage patients across across regions and across the various caregivers in our area. And of course, the obvious thing that healthcare people think about is, how do I get the patient to come to me? And what we're learning is, for high value, what you really want to do with a lot of patients is send them to them. Because them is going to be able to do it cheaper, because they don't have all the overhead we do, and them is going to have more volume and expertise in that particular area that this patient has. And instead of trying to do everything for everybody, which is another disaster in healthcare, which never works, and nobody can do that, we can substantially improve our value. Now, in terms of the care model, this is a picture you've all seen. You know, the traditional care model is the yellow bubbles. The patient goes on a journey across independent yellow bubbles in their care process. Which order they go in those bubbles, who knows? It depends on a lot of things. Okay, I'm going to do this. Where the patient starts, who they see first, what the person they see first, thinks, what they do next. Literally, the order of the bubbles is going to make a huge difference to success. And who are the individual people that they actually see, which is usually heavily, I wouldn't say random, but it's idiosyncratic. And the ability to coordinate care when all these people are separate yellow bubbles in their own department, facilities, and working with their colleagues in whatever field they're in, the coordination is almost impossible. You'd spend all your life coordinating with the traditional model. And you could send around notes, but notes are very imperfect, okay? On the right is the integrated practice unit model. It says we co-locate in one organization, all the skills and expertise we need to care for whatever set of conditions we're going to care for across the whole cycle of care. We try to have as many of those people dedicated to head and neck, co-located potentially in a space that is not a specialty space, it's a head and neck space. But we do have to bring in help for unusual things. An integrated practice unit should be able to deal with all the predictable, regular complications and comorbidities. A diabetes center can't just have endocrinologists. It's got to be able to worry about the eyes and the vascular and the nephrology and all those things. So we got to put together in our IPUs the people that are routinely and typically involved in care with common complications and common comorbidities. But then we're going to have to bring in people from the outside, because we can't afford to have that next level of specialties who once in a while we need. And those are going to be shared with our broader institution, and how to build that integration with people who only work with you once in a while is complicated. But the number one way to do that is, if you're going to call on a plastic surgeon, call on the same one every time, so that plastic surgeon really gets to know head and neck cancer and can become a real expert in doing the plastic surgery work that involves, or whatever, okay? What we have to do is make a fundamental reorganization in care, and what we discover is a lot of people don't particularly want to do that. Oh, I kind of like working in my department, and I kind of like working with these people, and I want to do things in my own facility so we get the revenue. I don't want to send this out to, this other unit. So we've got some barriers to getting this done. But we have some of these in head and neck cancer. And I think that's because you guys understand that you can't deal with this in silos. You've got to see that multiple people have to be involved that have a lot of expertise and skill that are collectively necessary to care for this disease. I won't go through this, but we're starting to understand that there's kind of a playbook. If we're going to organize an integrated practice unit that takes that responsibility across the whole care cycle, there's some rules of the road of what we want to do. For example, we need to meet. Now, you guys, most of you, are involved in tumor boards or whatever you call them. And actually, there's a paper that's out there now that I had a minor impact on that actually showed that tumor boards are valuable. They change diagnoses. They get the best minds together to come up with a better answer. And so we all have to have a process for getting the best minds together in this multidisciplinary disease we have. And we got to not view that as a pain in the butt. Oh my God, we have to go to a meeting. And we say, I can't wait to go to the meeting because this is going to allow us to be really, really good. We need to do multidisciplinary rounds. The really best care delivery organizations we discovered in the world meet all the time. Not for hours and hours, but they find ways at many moments over the care process to connect with the people they need to connect with. Not send them an email, but actually, work together. What we also find, I don't know if I can go back, that previous slide, and I won't try to go back. The previous slide made a very, here it is. The previous slide made a very simple point is that in value-based healthcare, volume matters. You can't deliver value unless you have the right volume or enough volume to actually have the right team. And for that team to get experienced. Again, you all know this. Volume is one of those things in healthcare. We know how powerful the volume is in getting better results, but we fragment ourselves. Every hospital in our system wants to do a little bit of everything. And therefore, we kind of fragment the volume, and therefore we don't have the volume in any one site to actually build that core IPU, and then it can connect with the other sites to do more specialized work, but that's not the way we operate. When we have volume, we can have sub-specialization. We really need sub-specialization in this field. I've come to understand from AHNS, this skull-based tumor thing, that's not so easy. We can't just do one of those once in a while. We need to do those a lot if we're going to do really well. And we got to have enough volume so that we can have a skull-based person that has that experience and somebody else that's doing the larynx and the pharynx and all the other things that we do, okay? So subspecialization is critical to value. And if we don't have any volume, then we're going to have a hard time doing it. We got to measure. I've already talked about that. Healthcare is a field of every field I've ever worked in where there's the most confusion about the word quality. What's quality? And we've come up with all kinds of definitions of quality. One is you follow the evidence-based guideline. Or you check indicators of how you might be doing, like a PSA score or a surgical margin. And if we have good performance on surgical margin or HbA1c compliance in getting the patient's A1C controlled, we're good. I once had a very interesting discussion with a CEO from a hospital in Europe who had won the European award for HbA1c compliance and control. They were brilliant at that. And I met her like just before she was supposed to get the award, and she looked sad. I said, how could you be sad? You've won this big award. You're great at this. And she said, well, we also have the highest amputation rate. Okay? So we control the HbA1c, but that's not the whole game. And so we can't just think about, did the PSA score, did we do something relevant to the PSA score or these other scores? We've got to, ultimately, quality in healthcare is one thing at the end of the day on this chart. Outcomes. Outcome is how the patient actually does in the things that matter to that patient. We spend so much of our time in healthcare not on performance, but on compliance. Do we comply? Not how well did we perform. We have to change that mindset. It's not that compliance isn't useful. Yes, in general, we want to do evidence-based stuff, but that's not the end. That's the beginning. And unless we measure the outcomes and look carefully at the outcomes, we won't understand what all this other stuff actually matters. In England, I have a massive, fierce debate every time I go about patient satisfaction. The Brits always tell me, oh, patient satisfaction is the outcome. And they're really, really committed to measure patient satisfaction. I say, it's great to measure patient satisfaction. Press Ganey will love to do it for you. But guess what? What if they die? And they had a great experience, and they liked their caregivers, and they thought they were respectful, and things were all that. Well, it's important, but it's not the ultimate outcome. So I think we've gotten away in healthcare with actually not having to confront this hard problem of measuring outcomes. And we're going to have to change that. When we think about outcomes, we introduce this framework called the outcome measures hierarchy. It says that for any medical condition, there's multiple outcomes that matter. Always multiple outcomes. And you see this chart, and there's clinical status or clinical outcomes. My cancer is in remission. And then there are functional outcomes. Oh, I can go back to work. And what we've learned is we tend to measure the clinical and not the functional. And that's why there's this giant movement called patient-reported outcomes, PROMs. Because really we need the patients to help us understand the functional outcomes. And we can't have a nurse, figure out whether their, mobility status is. They can take a crack at it, but we really need patient-reported outcomes. So all good outcome measurement now involves patient-reported outcomes. And head and neck is no example. Can I eat normally? How am I dealing with this disfigurement? And so on and so on and so on. So systematic outcome measurement is key. I mean, here's a fascinating example from Germany where they've managed, actually, all the German centers that do prostate cancer have now agreed on measuring a certain set of outcomes. And what we can see is on 5-year disease-specific survival, everybody's the same. That's really pretty much driven by the disease. But there's other outcomes. Severe erectile dysfunction after 1 year. A lot of variation. Incontinence after 1 year. A lot of variation. And I can tell you that the patients care about both. They kind of expect they'll do okay on the top one. But what's really critical to them is, what's my life going to be like, for the next N years? So we've got to learn how to measure that whole set of outcomes, but we need to standardize it. We can't have, this hospital measuring it this way and this hospital measuring it that way. That's another problem we've had in outcome measurement. Everybody does their own thing, except in a few fields, like the Society of Thoracic Surgeons, that started down a path that I think has been very powerful in that field. But if we all measure different things, then it's not going to give us what we need. Here's a field where we have universal, standardized outcome measurement as well as risk adjustment. Transplants. Many of you know this, know a lot about this field. This happened because some bureaucrat said, aha, all these people that are doing this need to get organs. And so let's do this. You can't get an organ in the organ system unless you measure the outcome of every single patient that you treat. And what a momentous decision that was. This is the first data set that came out of it for kidney. We have it for other kinds of transplants. And you can see the tremendous variation. You can also see that it's hard to prove sometimes statistical significance because there's just not enough of them in any one center to have. So it's only the kind of red dots that are worse than expected, and the green dots, which are hard to see, that are better than expected. So some purist will say, well, if we can't prove statistical significance for everybody, then we shouldn't do it. No, no, no. We got to do it anyway. Because the very fact that we actually go to the trouble of measuring this, and we can look at ourselves and see where we fall on that map, is going to get us to do the kind of things we all need to be doing, which is figuring out how to do it better. Oh, no. I forgot. Sorry. I'm so sorry. So here's what happens when you measure outcomes. This was the first data set. They're 3-year data sets because of degrees of freedom. here's a recent data set. It's magic. And everywhere I've ever looked, we've looked worldwide for universal, consistent measurement of outcomes. This is organ transplant, cystic fibrosis. Wow. And many, many other fields. So we simply, as hard as this is, we have to take it on. And this society needs to do it as a society. Not just thousands of flowers blooming. We're going to have the most beautiful joint garden in the world if we can do this as a society. I founded an organization I won't go into in detail called AHNS. We decided that one of the big constraints to value-based healthcare in the world was the lack of standard outcomes. So you can see here that for a whole lot of medical conditions, a process was created involving global clinicians, the best people in every given field, to come together and talk about this for months and figure out we got to measure this at minimum. What are the minimum things we need to measure? Those are called standard sets, and those are published. They're free of charge, and they're getting measured now in thousands and thousands of providers all around the world. If you look at that list, you're going to see the big cancers, but you're not going to see head and neck. So hopefully next year, or if I ever get invited back, we're going to have head and neck on that list. And we're probably going to have multiple ones because of the different variations of head and neck cancer that are very different in terms of what you want to measure. Okay, we're almost out of time. We got to do costing. Most of the people sitting in this room probably think that costing is the most boring thing on the face of the earth. Why would I want to talk about costing? I will tell you that if you do the costing the right way, you're going to have a lot of fun with it. And the reason is that the right kind of costing is called time-driven activity-based costing. And to do costing right, you've got to map out your entire care process. And obviously you can do it over time. And this is the intake process at MD Anderson. And what you see is there's various decision points, and each color is a different kind of person you're seeing, a doctor, a nurse, X, Y, Z. And the numbers in the circles are how much time was devoted by this resource to the average patient with whatever disease it is. Because what we find in healthcare is all the resources are shared. Okay? You're sharing your rooms, you're sharing your equipment, you're sharing your physicians, you're sharing your nurses. And to understand cost, we have to figure out how much time is being taken up by an individual patient on all these things as they go through the care process. If we can understand that, I will guarantee you, you can have a substantial impact on your cost because you'll find, oh, this is inefficient. You know, we spend too much time talking to a patient about their MRI and not doing the MRI. So how can we get patient in that machine as soon as possible and prepare them for that, but not keep the machine waiting while somebody is sitting there having a conversation. Conversation is nice, but it just costs us a lot, and that patient's going to have to pay the copay, not just you. A lot of cost reduction opportunities here. Robert Kaplan is a leader in cost accounting that has worked with me on this body of work, and again, we've done many pilots of individual conditions in Mayo and Cleveland and all kinds of healthcare delivery organizations, and we're finding 30% cost reduction. It's not unusual. If we could reduce costs by 30%, guess what? We'd solve the healthcare problem in the world. But we haven't had the data and the analytics and the discipline to do that. But we will, we must. We're starting to move towards value-based payment. I don't have time to discuss this in detail, but there's capitation and the ACO model, which is actually not quite the right approach. Because it's looking at a population, not a condition. And the reason that ACOs haven't been powerful is they have not aligned that model, payment model, with the right unit of analysis, which is the condition. The bundled payment model is aligned with conditions. You're going to have a hip replacement, and you get a single payment that covers everything that's involved in that hip replacement over the full cycle of care, and your outcomes are measured, and you can get a bonus if you can exceed, the expected outcomes, and you get rewarded for value. If you do it cheaper than the bundle payment, you get to keep it. It doesn't go to the department then they use it for, whatever they use it for. The most powerful customers now are not the health plans and not CMS. It's employers. This is Walmart. If you look at on the left, those are the conditions where Walmart has bundle payment, and they've made agreements with the best providers they can combine, which are on the right, and essentially they offer the bundle payment for this service if you go to one of the providers that actually has some evidence that they're really good at it, and guess what's happened? It reduces costs by 1/3. Walmart saves 1/3 by doing this because they get the patients to the right place, they have this motivational bundle payment, and people do a great job. There's a tremendous reduction in inappropriateness of care because the people that know what they're doing and are being focused on value don't have inappropriate care. They just don't do it. They realize it's not a good idea. It's a waste of money. And there's also very, very good outcomes from this model. So I just want you to understand this is happening. There's been an effort at a head and neck cancer model. It's quite complicated because patients vary so much depending on what modalities they get. So you've got to have a more complicated bundle there that reflects modalities. It's very hard to sort of do that, by saying in this kind of pharyngeal cancer, here's the bundle. Because it's so nuanced that you have to give opportunity for modalities to be reflected in the bundle price. We've got to integrate across our health systems. Mass General and Brigham have got to decide which services they're going to share and which services Mass General is only going to do and which services the Brigham is only going to do and which services they need to put out to their community hospitals that they have quite a few of now. That's what we call systems integration. The big message here that you should think about, you should always think about this every single day. You've got to get the patient to the right place for the highest value outcome. And you know that. You know what that is. But we've got to do that. But that's not been our culture. And we've got to put in the right IT system. I'm sorry. It's very expensive. It'll get better. So what are the priorities, just to conclude, and I'm probably over a little time, but we did start a little bit late. Think beyond the operating room. Think care cycle for whatever you're doing. Think the whole care cycle. And you got to enlist the whole care cycle to actually deliver the best results. We've got to get universal outcome measurement and public reporting of that in this field. We got to be able to do what the transplant folks are required to do, and the cystic fibrosis people have been encouraged to do by the foundation in that field. And we're seeing in a lot of pediatric conditions. There's quite good outcome measurement. There's been more of a spirit. Let's work together, figure out what the right outcomes are, and we'll all report it. In congenital heart defects, for example, that's a good area. So we got to do the outcome measurement. We've got to actually understand our costs. We can't just punt. We've got to start down the path of changing reimbursements and start negotiating with employers and others to create a different payments model. It can't be worse than the existing one. And then we need to start making sure that our patients are in the right place. And if somebody really needs to get to a highly sophisticated MD Anderson-like IPU, they get there. And the community physician doesn't try to do it because there's nothing else we can do. But we got to create incentives for those community physicians, so we need to send them back patients to have stuff done that they can do well. And we need to get them to understand they're part of the team. And they're part of this care delivery process, and that's not bad. And they'll actually probably make more money in the process. Think care cycle. So, what I would tell you is this is happening. Value-based healthcare is happening. It's happening all over the world. I personally have been involved in many, many dozens of organizations to do this. I will simply tell you, I think we know how to do this. I think we know what to do now. For a long time, we didn't know what to do, so we tried prior authorization. That's not going to be powerful. I think we now know what to do. We know that as long as we make value the true north of what we're doing every day and how we're thinking about doing it better, we're going to go in the right direction. It's going to help us restructure our organizational model. It's going to help us change our measurement. It's going to help us integrate our health systems better. Outcomes, of course, are critical. We are very excited about employers. Employers are now getting more adventurous in engaging directly with us in healthcare rather than just paying the insurance company. And even CMS, got to give them a lot of credit for efforts they've made to move the value agenda. But this has been a start. We could go much more, but I hope that in the coming years, this society, which has got so much going in the right direction about value, can simply take this forward in an even more powerful and unified way. And I can tell you, if you get yourself into this model, you're going to like it. It's a dream to practice in an IPU that thinks this way. It's incredibly rewarding. And even though you don't want to give up what you've been doing, I promise you, if you can get this going in your organization, you're going to have a lot more fun. You're going to be a lot more productive. You're going to not do things that you don't need to do anymore. You're going to get a lot more satisfaction out of your job. So let me thank you. Sorry to take a little bit extra time, but it's a privilege to be here. Thank you.
Thank you so much, Professor Porter. And on behalf of the American Head and Neck Society, I'd like to present you with this certificate and award that says the American Head and Neck Society wishes to thank Michael Porter for presenting the John Conley Lecture, Value-Based Healthcare, the Agenda for Head and Neck. Thank you.
That was really nice.
Thank you very much. That was phenomenal.
You got most of it.
That was phenomenal. That was great. Thank you so much.
Did I say anything wrong?
No, not at all. You did a fantastic job, and I think